Well, good evening, everyone. And for those of you who are joining in for the first time for part 2, welcome to this webinar. And for all those who are returning to this, welcome back to part 2 of this webinar. So I would go and share my slides now. Yes. So happy Teachers' Day to all of you. And I must say that I'm really privileged to be a teacher myself. And at the same time, I bow my head before those fabulous teachers whom we have in the fetal medicine scene in not just India, but in the whole world as well. So welcome all of you with a happy Teachers' Day message. I must also thank, like last time, the Society of Fetal Medicine for this wonderful opportunity and for LifeCell for sponsoring this and bringing this to you in such a uninhibited fashion. And this time I must also thank two of my colleagues, Dr. Veena Shenoy, who's the head of transfusion medicine at Amrita, and Dr. Ashwin Prabhu, who's one of our young dynamic neonatologists in charge of the ICU. Well, I do remember that I promised last time that I would start off with a recap of part 1 for those of you who could not make it then. But then I realized that subsequently the full recorded version of that first webinar is now available on the Society of Fetal Medicine website for free download. So you can log on and watch it. It's also available on the LifeCell webinar corner. So what I do is I'd rather skip a very detailed recap of part 1 for want of time and for not running the risk of sounding redundant. Instead, I would focus more on a few additional points that I thought should be mentioned in this particular part of this webinar series. But having said that, I do assure you that you would not feel a major disconnect between last time and this time, because I've taken a conscious effort to include connecting concepts or connecting links that would link you to what was discussed in the first part of this webinar. So I think like last time, it makes more sense for me to log out of the camera here, because I do not want to have technical issues with decreased bandwidth and stuff like that. And more than that, you would also get to see the full screen view if I log out my camera. So I'll come back in for the discussions, but for the time being, I would turn off my camera and then go back full screen. Right. So now what we discussed in part 1 of this webinar were the factors that lead up to a positive ICT. Whereas what we would discuss now is what do you do after the ICT comes back as positive. So if you remember, we had signed off the last part, or part 1 of this webinar, by taking a look at a typical scenario that comes to mind when we think of an ICT positive pregnancy. I think that's a good starting point for this part as well, because we said when you think of an ICT positive pregnancy, what comes to mind is a mother who's a second gravida or more than that, who's rhesus negative, married to a rhesus positive husband, had a previous pregnancy where the baby was rhesus positive, and this lady was for some reason either not given anti-D injection or was given but the anti-D did not work. And therefore, the rhesus positive antigen or rhesus positive blood cell from the fetus that would have escaped into the mother's circulation sometime during pregnancy or during delivery would have incited an immune response in the mother, and the mother would have produced anti-RH antibodies in her circulation. And these anti-RH antibodies, when they reach detectable levels, is when you would get a positive indirect Holmes test. So this is essentially what we discussed last time. Now, I hope you remember that I'd also shown you different clinical scenarios, in fact, 6 cases from recent practice, which somehow did not conform to this idea of a typical ICT positive pregnancy. Now, I would quickly go through these 6 case scenarios that we discussed last time, because I think that would set the premise for the rest of this lecture to follow. Now, the first case that we said was a 24-year-old primary gravida negative positive couple, but despite being a primary gravida, her ICT was positive at booking, which is not what you would expect. And remember that she did not have a history of any whole blood transfusion. The second case was a 33-year-old third gravida. She was Rh positive. Husband was also positive, and despite that, the ICT was positive at 19 weeks. Third was a 24-year-old second gravida, negative positive couple. First baby was positive, but indeed she was given INTD on the day of delivery. But despite that, the ICT became positive in this pregnancy when she was tested for the booking visit. Case 4 was a doctor couple who had come for the first trimester scan. Negative positive couple again. First baby was positive. And this time again, the NTD was given, and the NTD that was given was directly supervised by the husband, who himself was a physician. So you cannot say that there was a mistake in giving NTD, or the right dose was not given, at the right time, and so on and so forth. And despite all that, the ICT turned out to be positive in this pregnancy again. The fifth case was a lady with SLE, systemic lupus erythematosus, second gravida, negative husband. First baby was negative, and despite all three of them being negative, she turned out to be ICT positive in this pregnancy. The sixth case was a 28-year-old primey, negative positive. The ICT was negative at booking, but when it was repeated at 30 weeks for some reason, it turned out to be positive. So these were the 6 cases that I had ended with last time. I would leave it at that now, but I promise you that I'll come back to them sometime during the course of this lecture, or probably towards the back end of this lecture, and explain to you what happened in each of these 6 case scenarios. But for starters, what exactly does an ICT positivity mean? Well, in the simplest of terms, it means that this lady that you are dealing with or looking after has some undesirable antibodies in her circulation. In the simplest of terms, it is that what means. If the ICT is positive, she has antibodies in her circulation. Now, these antibodies have been produced, as we know, in response to an antigen. Most likely, a foreign antigen that entered this lady's circulation at some point in her life thus far and stimulated her reticuloendothelial system to produce antibodies. Now, in the setting of a pregnancy where you presume that the mother is rhesus negative and the partner is rhesus positive, these foreign antigens are most likely to be rhesus antigens. And amongst rhesus antigens, they're most likely to be the capital D antigen, as we discussed last time, because that is simply the most common and most prevalent antigen of the Rh factor, those 6 antigens that we discussed about last time. Now, I know I've made a very long sentence, and it might have sounded confusing to at least some of you, but every phrase that I used in this sentence was intentional and carried meaning. When I said that this antigen would have entered her circulation at some point in her life thus far, what do I mean? I mean that these sensitizing events that stimulated the production of antibodies need not always be a prior sensitizing pregnancy. It could also be an unmatched or a mismatched blood or platelet transfusion. And I said the antigen was most likely a foreign antigen. When I said that, it opens up the possibility that not just foreign antigens, but even autoantigens could result in an antibody production and therefore in a positive ICT. And I said that the mother is presumed to be rhesus negative because, make no mistake about the fact that even rhesus positive mothers could have a positive ICT. We'll come to that in a while. I specifically chose to say rhesus positive partner and not husband because we must understand that paternity could be other than what is stated. Or in other words, the biological father and the legal husband need not be the same person. I hope you understand what I mean. And I said the rhesus and the antigen that is likely to be the culprit here is most likely a rhesus antigen because, as we discussed last time, even non-rhesus antigens could cause a positive ICT, could cause antibody production and therefore a positive ICT. And I said amongst the rhesus antigens, it is most likely the D antigen, which means even in the rhesus factor group of those 6 antigens, antigens other than the capital D antigen, like the small c, the capital C, the small e, the capital E, etc., could also incite an alloimmune response and lead on to a positive Coombs test. Now, in other words, if you look at an RBC, it has got a lot of antigens on its surface. And it's very clear from this picture that these antigens are not all belonging to the ABO group or the rhesus group. Now, these antigens just include, amongst others, the ABO groups and the ABO antigens and the rhesus antigens. There are a whole lot of other antigens, and all of them could potentially incite an alloimmune response in the mother if she is negative for any of them. To elaborate further, close to 50 red cell antibodies have been discovered to show clinically significant, or to result in clinically significant hemolytic disease of the fetus and newborn, HDFN as we call it. Now, if you look at this big list, not all of them are rhesus antibodies, not all of them are capital D antibodies. There are a lot of other antibodies that have shown to produce clinically significant hemolytic transfusion reactions or hemolytic disease in the fetus and newborn. But having said that, the clinical effects of these are not the same. There are some that are known to cause severe disease, some that could cause mild disease, and some that have never been shown to cause disease in the fetus or newborn, which is why these antibodies have been categorized based on their clinical significance into 3 groups, with group 1 being the most strong antibodies that are commonly associated with significant hemolysis and hemolytic disease in the fetus and newborn, while group 3 have never been documented to cause clinical hemolytic disease. So that's how these antibodies have been grouped, and all of them are red cell antibodies. And remember, all of them, if present in the mother's blood, would show a positive ICT. So it's not always anti-D antibody that we're dealing with. Now, having said that again, if you go back and look at this particular table, it is quite obvious that the most severe reactions are produced predominantly by the rhesus group of antigens, or the rhesus antibodies. Now, the only exception there is the KEL antibody. Now, the KEL antibody is quite unique in the sense that, one, of course, it is belonging to group 1 and therefore could cause clinical hemolytic disease of certain significance. But more than that, it is also unique in the fact that this is one antibody which, if present, you would expect that the fetal effects do not really correlate well with maternal antibody titers. Now, the reason that when the antibody involved is a KEL antibody, the fetal effects do not correlate with antibody levels or titers is because, unlike the D antigen or any of the other rhesus antigen or antibodies, KEL antibody causes anemia by a dual mechanism. One, of course, is like all the other antibodies, it can also cause immune-mediated hemolysis and red cell destruction, and therefore can cause anemia. But a unique property of the KEL antibody is that it interferes with early proliferation of immature red blood cells. Now, this dual mechanism is what causes fetal effects to outweigh the maternal antibody titers. So, in other words, if you take 2 cases, one with KEL antibody and the other with capital D antibody with the same antibody titers, you would expect far more severe consequences in the mother with. You would expect far more severe fetal consequences in the mother with the KEL antibody rather than in the mother with the anti-D antibody for the same titer value. That is because KEL antibody interferes with proliferation of immature RBCs as well. And that is why the KEL antibody has attracted this tagline of KEL kills. Now, how do I know, in my particular case, which of these antibodies has caused the positive ICT? That is where the test called as an antibody identification test comes into significance. Now, does it really matter? In other words, do I really need to do an antibody identification test in all my ICT positive pregnant women? Well, the answer is it certainly does help if you have the wherewithal to do it, because it tells me exactly what to expect in this particular case. I'm much better prepared, and I can optimally utilize my resources and train my guns on those patients or those women who are at high risk of fetal hemolysis. Let me give you an example. If we go back to case 2 that we discussed earlier, the RH positive lady who had an ICT positivity at 19 weeks, third gravida. Now, in this particular case, the antibody that caused the ICT positivity was not rhesus antibody. It was a non-rhesus antibody, the anti-Lewis B antibody. And you can see from this report that my ever-smart transfusion medicine specialist, Dr. Veena, has told me that anti-Lewis B antibody is usually not clinically significant. Why did she say that? It's because if you go back to this list and see, anti-Lewis antibody is a group 3 antibody. It has never been documented to cause clinical hemorrhagic disease of the newborn. So how does this information help me? One, my patient need not worry as much because I know that Lewis B antibody is not going to cause severe hemolysis in this baby. Second, I know for a fact, and I'm going to tell my patient that your chances of fetal anemia in this pregnancy are extremely low compared to another lady with an ICT positivity who's got a D antigen or another rhesus antigen. And therefore, because the chances of anemia are less, I would put her on a less frequent follow-up regime, and she need not come back to me every 2 weekly or 4 weekly for serial ultrasound monitoring. Now, having said that, if you talk about non-rhesus antibodies, how common are these in our practice and how significant are them in daily practice? Because this lecture is all about A to Z guide to daily practice if an ICT positive pregnancy comes to you. So how common are these? Now, here are 3 studies from India, one from Vellore, one from Delhi, and one from our own center, a small study, which looked at the prevalence of red cell antibodies in the Indian population. Now, the column or the row that I would like to draw your attention to is this particular row here, which looked at the prevalence of red cell antibodies in rhesus positive females. You can see that even though the incidence or the prevalence of antibodies in rhesus positive females is comparatively very low compared to Rh negative females, it is still not zero. There are cases of antibodies that have been reported in rhesus positive females. And unlike in our case, where it was a very weak antibody, the Lewis B antibody, if you look at data from the other 2 centers, they have come across antibodies, non-Rh antibodies in Rh positive females, which also belong to groups 1 and group 2, which means they could possibly cause significant complications of fetal hemolysis. And if you look at these antibodies, these include the KEL antibody, the FYA antibody, it was reported in the study from Delhi, which are both group 1 antibodies, whereas the Vellore study described antibodies like the JKA, the JKB, and the S and M antibodies, which belong to group 2. So our particular patient was lucky because she had a very weak antibody, but there are rhesus positive mothers who could have a positive ICT and in whom the antibody could be strong enough to cause fetal hemolysis. Now, the other point that we need to understand is that the same study from Delhi said with every subsequent pregnancy, the chances that you might encounter one of these irregular erythrocyte antibodies or non-common or uncommon or non-regular erythrocyte antibodies keeps on increasing with every successive pregnancy. For example, if you look at this row, if the prevalence of such antibodies is as low as 0.9 in the second pregnancy, when you go to the 5th pregnancy, which is not uncommon in many parts of India, you would expect irregular erythrocyte antibodies to be seen in up to 7% of females, Rh positive females. So the point that I was trying to make from this particular case is that if you have the wherewithal to do an antibody identification, it certainly does help, as is seen in this particular case. And the other take-home bonus point that we got from this particular case is that ICT should be offered even to rhesus positive women at booking, because even they could occasionally turn out to be positive for the ICT because of a non-rhesus antibody in their circulation. Now, another case that would confirm this is case 4, the doctor couple that we spoke about, where the anti-D was given and supervised by the physician husband. Now, the culprit antibody in this particular case was a non-D-Rh antibody, the anti-G antibody that we discussed about last time, otherwise called as the anti-C plus D antibody. Now, I do remember that we spoke at length about the anti-G antibody in the last part of this webinar, but because there were more than a few questions on this during the discussion, I thought it is best and apt that I include a little more detail on this particular antibody. Now, when we ask the lab in an ICT positive female, so you have an ICT positive female, and I call up my transfusion medicine expert, Dr. Veena, and tell her, Veena, I want the antibody identification to be done for this particular lady. What she would do first is to do what is called as a basic antibody screening, where you look for the common antibodies in the mother's bloodstream. Now, in some women, when you do this basic antibody screening, the serum would show a reaction in both the anti-D well and the anti-C well. Now, when you see a reaction of agglutination in the anti-D well and in the anti-C well together, it could mean one of 3 possibilities. First, she could have both anti-C and anti-D antibodies in her system. Or second, it could be an anti-G antibody, which, as we said last time, has got properties very similar to anti-D and anti-C antibodies because of a structural similarity in the epitopes, which is different only by 1 amino acid. So it would show cross-reactivity with D and C, but it is neither D nor C. It's a completely different antibody called as anti-G antibody. So even if you have an anti-G antibody and no anti-C or anti-D, it would show a reaction in the well. The third possibility is you have an anti-G with either of the other 2 antibodies. So all of these 3 case scenarios, you would get a reaction in both the anti-D well and the anti-C well. So how would you differentiate between this mix? Now, that is the area of interest of a really inquisitive immunohematologist or a transfusion medicine expert. And I think it is best, like we discussed last time, to leave such difficult scenarios to them, because they would be required to do what is called as a double adsorption and elution technique in an extended cell panel. These are the words that Veena mentioned to me. I just copied and pasted it here. I myself do not really understand what each of these mean. But there are techniques like this by which you can actually differentiate and find out from an extended cell panel as to whether the actual culprit is the anti-G or whether it is anti-C and anti-D playing a confusion game here. Now, why am I so bothered about this? Why is it important to identify anti-G? Now, if you go back to this slide from the last part of this webinar, if you arrange the Rh factor 6 antigens out of the 50 Rh antigens according to their immunogenicity, capital G antibody, we said, is the weakest of the lot. And also because it is the weakest, I would expect the chances of anemia in this particular fetus to be very, very low, unlike if it was a capital D or a capital C antibody. And also, if you're sure, or if your hematologist tells you that this is indeed anti-G that is present alone in this mother, it means she has still not been sensitized by the D antigen, and therefore there's every reason for you to give her anti-D prophylaxis in this particular pregnancy, even though the ICT is positive. Now, remember, normally we say if the ICT is positive, there is no role for an anti-D. But here is an example. If you know that the antibody identification test is possible and you've done it, and the antibody identification test tells you that this is not anti-D but an anti-G antibody or any of the non-D antibodies for that matter, here is a candidate who needs to be given anti-D prophylaxis despite the ICT being positive. I hope I'm clear on that front. So what I've been trying to tell you from these 2 case examples of case 2 and case 4 is that if you have the facility to do an antibody identification test to your ICT positive mothers, It definitely adds a positive dimension to your practice because you can, as I said, train your guns on patients who require them the most. You can optimally utilize your resources to those patients who require them most, and not end up worrying too many patients who really do not require to be worried. Now, again, having said that, how commonly available is the antibody identification test? Now, I do agree that the antibody identification test is not something that is widely available. And if in your setting this is not available, as is what we would expect in most centers in our country, that is where you would apply the rule of commons. Now, what is the rule of commons? The rule of commons is best explained by the analogy of a black flying bird. If tomorrow morning you step out of your house and see a black bird flying overhead, and I ask you, what is this black bird most likely to be? The obvious answer would be a crow. At least in India, it would be a crow. Now, if I ask you back, can this not be a black mutant of a white Siberian crane? Well, it can be, but you would know, just as I would, that the odds of this being a black mutant of a white Siberian crane is extremely, extremely rare. Now, we apply the same rule of commons to this particular list of antibodies. If you do not have the facility to do an antibody identification test, the next best thing to do would be to assume that the antibody that caused the positive ICT in your particular patient is the capital D antibody, because this, as we said last time, is the most common, the most prevalent, and the most immunogenic of the list of antibodies. Now, with that, we come to the next segment of this webinar, which is the fetal effects of a positive ICT. Now, again, if we go back to this particular slide from the last webinar, or part one of this webinar, we are now talking about a lady who is at this particular stage in this progression that we discussed last time. In the sense, you're talking about a first alloimmunized pregnancy where the lady has tested ICT positive at booking because she has antibodies in her circulation from a primary sensitizing pregnancy, or rarely from a sensitizing event other than a pregnancy. For whatever reason, she has antibodies in her circulation, and this is what has caused the positive ICT. Now, if this fetus in this particular pregnancy carries an antigen to which the mother already has antibodies, and which is what caused the positive ICT. And these antibodies we know are likely to be IgG antibodies, and they would cross the placental barrier. They would attack the fetal blood cells and start causing fetal hemolysis. Now, once that happens, the first alloimmunized pregnancy gets recalled as a first affected pregnancy. So what are the effects of fetal hemolysis? Now, the effects of fetal hemolysis can vary from mild anemia at one end of the spectrum to severe cardiac failure and hydrops at the other end of the spectrum. But remember, there is always a time lag between the onset of clinical anemia and the development of severe cardiac failure or hydrops. Now, if I manage to pick up anemia early and interrupt this timeline early enough in its progression, the earlier I intervene, the earlier I break this time lag, better would be the outcome for that particular pregnancy. So the question is, how do I do that? How do I achieve this? Or in other words, how do I diagnose fetal anemia early in this natural history? We should remember that a positive ICT will not tell you this. A positive ICT only indicates that because there are antibodies in this mother's circulation, there is every possibility of this fetus being harmed. What a positive ICT will not tell you is the extent of fetal harm that is likely to occur. Now, the extent of fetal harm would depend on the type of antibody, which is what we listened to so far in this lecture. It would also depend on the titer of the antibody, which is what we're going to discuss from now on. Now, the antibody titer is always expressed as a fraction 1 in x and is defined as the highest dilution at which antibodies are still detectable in the serum sample after serial dilution. For example, if I say that a lady's ICT titer is 1 in 32, what it means is that if I dilute her serum sample 32 times, the antibodies are still seen, or there's still coagulation. But the moment I make the dilution 1 in 64, the antibodies disappear. So the least dilution, the highest dilution at which antibodies were still detectable in this case is 1 in 32. And therefore, the antibody titer of this particular lady, or the ICT titer of this particular lady, is 1 in 32. And it goes without saying that higher the denominator, greater would be the antibody load. Now, again, the question here is what titer is clinically significant? Now, this is something that only your lab can tell you. Every lab that does ICT titer is supposed to maintain a logbook or a record of what is the least antibody dilution at which, or the titer at which, fetal hemolysis has been reported in those cases that have been reported from that particular lab. Now, in most cases, this value is 1 in 16, and this value is what we call as the critical titer. In other words, the critical titer is the value below which no case of fetal hemolysis has been reported. As I said, most labs, this would be a value of 1 in 16, but there are labs where it is 1 in 8, some where it is 1 in 32. Now, the catch in this that I want all of you to understand is that there are different methods for titer estimation. The conventional method is what we call the tube agglutination method, which is supposed to be the gold standard testing method for this. But a more commonly done technique is what we call the column agglutination method, otherwise commonly called as a gel method. Now, the reason why there is a catch here is that critical titer, which is crucial to managing these pregnancies, have only been established for the tube method. But most labs these days would test for titers by the gel method. Now, this is because from a lab technician's perspective, the gel method has a lot of advantages. One, it is much more sensitive, even traces of antibodies can be picked up. You require a very small volume of sample compared to the tube method. The results are far more stable and reproducible, and the reaction endpoints are much more standardized than you would expect from a tube dilution method. Now, having said that, from a clinician's perspective, the gel method would show significantly higher titers than the tube method. This is a very important point that we need to understand, because there have been studies that have shown that the mean titer when you do it by a gel assay could be 3.4 times that what you would see with a tube assay. And this study said there could be as high as 8-fold difference in titers when you do it by the gel method. And as I said, most labs do the ICT titer by the gel method these days. And in the same study, they said with samples, when they looked at samples with titers that were less than 8 by the tube testing method, and they repeated the same with the gel method, 92% said the gel titer was above 16, and 70% said the titer was above 32. Now, why is this a problem? The problem is, if you look at this particular case, this lady was referred to us with a gel titer method showing an ICT titer of 1 in 128. So she was referred for monitoring of the fetus. Now, as is our practice, we repeat the titers by the gel method in our particular lab, and this came out to be 1 in 64, which you would expect is a high titer if you go by the critical titer for the tube method. But if you repeat this titer by the conventional tube method, the actual titer is only 1:8. So if I had not known this, and if I had not tested this lady repeatedly by the tube titer, the conventional tube titer, I would assume that the titers in this lady are very high. The titers of 1 in 64 is much above the critical titer of 1 in 16 in most labs. And therefore, I would expect severe fetal anemia in this fetus and keep a very, very close surveillance on this fetus and on this mother, where in reality, she has not even reached the critical titer. So what is the solution here? The solution is to identify, as this paper rightly points out, identify critical titers for the gel method. Unfortunately, most studies that have reported on critical titers have been only on the tube method. And hardly any studies that have looked at critical titers for the gel method. Now, we at our hospital teamed up with our transfusion medicine expert and the OBG department and tried to address this particular issue. And finally, we came out with a publication that was published this year, early this year, in the Transfusion and Apheresis Science Journal, which is regarded as a white journal for transfusion medicine experts, where we tried to define critical antibody titer by the column agglutination, which is the gel method, to guide fetal surveillance. Now, the key findings from this study were we had a sample size of 64 ICT positive samples, and of these 64, 27% samples that showed a positive ICT by the gel method were actually negative when you repeated them by the tube titer method. But in those samples that tested positive by both these methods, there was indeed a strong positive correlation in titer values between the tube method and the column method, which goes to tell you that whatever method you test by, if there are antibodies, these antibodies are likely to increase as the pregnancy advances. Now, having said that, the median titers, as is expected, and as was shown in the previous study that I quoted, were significantly higher when you tested by the gel method. The median titer of 1:4 by the tube method, while it was 1:32 by the gel method. Then we tried to look at the critical titers for both of these methods by an ROC curve analysis. And we discovered that the critical titer for the tube method in our sample of 64 cases was 1 in 16, but by the gel method, this value was 1 in 96. Now, 1 in 96 is not a common dilution that we look at. We generally go 1 in 2, 1 in 4, 1 in 8, 16, 32, 64, 128, and so on. And therefore, we had to choose the next best option here. So either 1 in 64 or 1 in 128, because 96 is exactly midway between 1 in 64 and 1 in 128. Now, as we always keep saying, it's always safer to err on the positive side, and therefore we kept a lower cutoff and said that the critical titer, if you're going with the gel method, has to be 1 in 64 and not 1 in 16, as you would assume for the tube method. Now, again, in our set of samples, it was indeed 1 in 16 by the tube method, as is what was commonly stated. But if you're going by the critical titer of the gel method, your critical titer has to be higher at 1 in 64. And therefore, after the study, our protocol now is to test ICT for all our pregnant women in booking, even if she is rhesus positive for the reasons that we stated before. And if at ICT testing she turns out to be positive, the next thing we do is to do titers by not just the tube method, but also by the gel method. And we also called for a routine antibody identification test. So this is how one of our sample reports would look like. We first do the Coombs test, indirect Coombs test. This lady has tested positive for the ICT, which, as you can see there, is suggestive of the presence of alloantibodies in her bloodstream. Now, once we know that she is positive for the ICT, the next thing to do is to look at titers by the conventional tube method as also by the gel method. Here it was 1 in 2 by the tube method, and as expected, it was higher, 1 in 8 by the gel or the column agglutination technology. And the third thing that we do, as I said, is to look for the antibody identification. In this particular case, it was indeed the anti-D antibody, the most common of the lot. Now, so this gives you all the information that you require to actually plan the management of this pregnancy in a very effective manner. If there's anything more that you would want to add to this, is that you can actually replace the titers by doing what was called as an antibody quantification or antibody measurement test. If again you have the facility to do this, we discussed this last time. Most centers do not do an antibody quantification. There are several methods to do it, including flow cytometry, continuous flow analyzer, radioimmunoassay, ELISA, etc., so on and so forth. But all of them are expensive. So if you need a lab that has to run an antibody quantification program, you need to provide them, like I mentioned very clearly last time, with at least 15 to 20 samples a month. So unless you're working in a very, very high volume center, or you have a centralized testing facility, antibody quantification is not really cost effective in our part of the world. But if for some reason you have the facility to do it and a lab who does do this for you, then you have to remember the numbers of 4 and 15. If the antibody level in international units per milliliter is less than 4, the chances of hemolytic disease in this baby is very, very unlikely, but you can just put her on surveillance. But if it goes above 15, there is every chance of severe hemolytic disease if their baby is incompatible for this particular antibody. Now also remember, if you're using antibody quantification instead of titers, you would consider it to be significant if there is an increase in 50% from a previous level. So if it's either above 4 international units per ml, or if there is an increase of more than 50% from a previous level, then there is significant amount of antibody in that particular patient. I'm sure all this has sounded a little too complicated, at least for some of you. And if you think this is a real headache to get all this done, well, we're always there to help you out. Now, armed with this information that I have, I've done the titers, I've done the ICT, I've done the antibody identification. If I'm in a center that does antibody quantification, well and good, I've done that as well. So I have all the information that I need to manage this particular pregnancy. So what next from here on? Now remember, what we've been discussing is about a mother with a first alloimmunized pregnancy. The reason I'm still saying that is the management of a mother with a previous affected pregnancy is entirely different, and we will come to that after we discuss management of a mother with the first alloimmunized pregnancy. Now again, to simplify things, we would assume at this point that this mother with a positive ICT, the first alloimmunized pregnancy, the antibody that is involved here is the most common antibody, which is the anti-D antibody. So we would take this as a prototype for sake of managing this particular pregnancy. So what do we do now? You have the first alloimmunized pregnancy on hand. We have assumed that the antibody involved is anti-D, so we are not discussing an antibody identification test here. We would straight away go to look at the antibody titers. Again, assuming that this being the most common thing that we do, we're not doing the antibody quantification. So most centers would do just the ICT titers, and you need to look at the titer value to see if it is above or below the critical titer value. If the antibody titer is below the critical titer for that method, very important, if it's tube method, you go by the critical titer for the tube method. If it's gel method, you have to go by the critical titer for the gel method. And if the value is still below the critical titer for whatever method you choose to do, then you would repeat this monitoring or repeat the titers every 4 weekly if it's very low, or if it's nearing the critical titers, or if the titers are rising, you would increase the frequency of surveillance to once in 2 weeks. Now, if on the other hand, or the moment the critical titer is exceeded for that particular method, is when you would want to initiate ultrasound monitoring for fetal anemia and try and pick up anemia very, very early, as we said. Now, there are a lot of people, especially fetal medicine specialists, who would argue that if you come across a lady who is alloimmunized and if the ICT is positive, then there is, however small, a definitive risk of the fetus being affected. So why don't you just skip all these steps in between? Because titer, methods of titer estimation, antibody identification, all of these are complex scenarios, and you would need a really good lab is very, very heavily reliant on your transfusion medicine expert on the lab that does all these for you. So why don't we just skip all of these? We know that there is certainly a risk of the baby being affected if the lady is ICT positive. So just skip all these steps in between and directly start monitoring the fetus for anemia by ultrasound. Now, fair enough, this is something that can be done provided you have the wherewithal to do it and you are a trained fetal medicine expert or a radiologist or an obstetrician who is very skilled at doing ultrasound monitoring for fetal anemia. But having said that, there are a few collaterals here which we cannot choose to ignore, particularly when you look at a broader perspective of cases. Now, one is, of course, the access to this kind of expertise where you can confidently monitor a fetus by ultrasound and say this baby is anemic or not anemic. And you should also factor in the fact that when you say you're going to monitor this fetus only by ultrasound and skip all the steps in between, you're going to drastically increase the number of hospital visits and scans. And thereby, the cost involved is going to be much, much higher. You have to also think about the cost-benefit ratio here. And more important to all these is the kind of undue anxiety that you're going to cause to the mother if you tell her that you are an ICT positive lady and therefore there's every chance that your baby is going to get affected. Now let me show you a case in point to prove this further. This was a lady, 31-year-old, second gravida, who had gone for her first antenatal visit to a referring doctor at 18 weeks of gestation. She was negative positive. First baby was positive, anti-D was indeed given. This pregnancy, when the referring doctor did an ICT, it turned out to be positive with a titer of 1:32. Now, this doctor assumed that 1:32 is above the critical titer of 1:16. She didn't bother to look at what method was employed to do the titers. So she said, oh, you're at high risk for fatal complications. And therefore, we need to keep seeing you every 2 weekly till 30 weeks. So this poor lady was seen every 2 weekly with MCA Dopplers from 18 to 30 weeks. A total of 13 visits to the hospital just for Dopplers. And this fetus did not develop anemia till 36 weeks. So the obstetrician got confused at this point for some reason, and then she decided to refer to us for delivery, anticipating that there could be anemia and she was not picking it up properly, and the baby might need level 3 NICU care. So he was referred for delivery around 36 weeks. And as I said, as is our practice, we repeated the titers by both the gel and the tube method, and we did the antibody identification. And lo and behold, the titer of this lady by the tube method was only 1 in 4, far below the critical titer of 1:16. And again, we repeated by the gel method as well. And we now know that 1 in 32 is below the critical titer for the gel method as well. And again, surprise, surprise, we did the antibody identification, and it was not the potent anti-D antibody that was involved here, but a rather weak anti-E antibody from the RH group of antibodies. Now, if I had this information, or if the referring doctor had this information at 18 weeks of gestation, and if she knew, if she had bothered to look or ask the lab by what method this titer was done, and if she had known that there are 2 methods of testing for titers, and this was done by the gel method, where the critical titer is not 1:16 as is for the tube method, but is higher, then we could have saved a lot of hospital visits for this lady. A lot of scans could have been minimized. The cost involved would have been drastically different. We did a very rough cost analysis in this particular case as a prototype, and we realized that this lady could have been saved of at least 15,000 rupees at a very, very conservative estimate had this referring doctor had the information that we now have at 18 weeks itself. Now, forget the cost here. Imagine the kind of anxiety that this patient and the family would have gone through if only we had known that at 18 weeks that this is not a case that we need to worry about. The anxiety levels would have been much, much lesser. And this is something that you cannot really measure like you measure the cost that I just spoke about. So essentially, the point I'm trying to make here is that these tests or this protocol that we follow is not a luxury, but it is certainly beneficial if you can do it at the first visit, because all it takes is just one visit to a referral center or to a tertiary center or to an immunohematologist or a transfusion medicine expert who knows how to handle this. And therefore, this protocol that we follow is definitely a stitch in time that could save 9 later on, particularly if you are in a setting where frequent ultrasound scans and frequent Dopplers are a premium. So therefore, this is not a waste of time. It is not a futile exercise to be actually doing all these tests that we spoke about. Even if you're good at ultrasound, even if you're good at monitoring the fetus by ultrasound, there is nothing lost in doing these at the first visit, because a parallel that you can draw here is to inverting the pyramid of antenatal care. Now, it's a question of acting now versus reacting late, as is the case with inverting the pyramid of antenatal care. As we have very clearly been shown by Professor Kypros Nicolaitis and his group, that if you analyze every pregnancy in detail, if you test every woman early in pregnancy, right in the first trimester by a series of tests and scans, you can then categorize these ladies into high risk and low risk, and you can target your serial follow-ups to those who actually require them. So this was a concept of, rather than making it like a series of visits as you see in the left half of the slide, if you do a proper scan and screening test in the first trimester, you can decrease the number of visits that she makes to the hospital by a hugely significant number. Now, this is exactly what we're speaking about here in the case of Rh negative. If you can apply this to routine antenatal care, you can certainly apply this to ICT positive women as well. Do an ICT titer by the tube method in the first instance, or even if it's a gel method. You also do the antibody identification. Then you categorize. With this information, you can very clearly categorize these ladies into high risk, or those ladies who are at high risk for fetal effects, and those who are at low risk. And then put only those ladies who are at high risk at frequent surveillance. You can save a lot of cost, you can save a lot of time, you can save a lot of resources. You can also save a lot of anxiety to those patients, a significant proportion of whom would be actually low risk. So this is inverting the pyramid of care in ICT positive pregnancies as well. And I hope this is a concept that makes some sense to all of you. So what we've discussed so far is, as I said, managing a fetus with the first alloimmunized pregnancy. Now let's see how it is different when we are talking in terms of a mother with a previous affected pregnancy. Now, the essential difference between a first alloimmunized pregnancy and a mother with a previous affected pregnancy is the fact that when it is a first alloimmunized pregnancy, the fetal effects, as we said, would depend upon the type of the antibody, the titer of the antibody, and the blood group of the baby. Now, when you know that there is a mother who has already had an affected pregnancy in one of her previous pregnancies, then the first two factors are completely taken out of the equation, because you know that there is definitely an antibody that is significant, probably a group 1 antibody. So the type of antibody does not matter anymore, because you know there is a significant type involved. The titer of the antibody again is not significant, is not relevant now, because you know unless there was a titer that was significant, that the prior pregnancy would not have been affected. And as we said in the last part of the webinar, with every subsequent pregnancy, the titer of an antibody is only going to increase, never decrease. And therefore, the only factor that's going to determine outcome here is going to be the blood group of the baby. Now, that is the essential difference between the first alloimmunized pregnancy and the mother with a previous affected pregnancy. If this baby's blood group is indeed incompatible to the antibody that the mother is carrying in circulation, then of course there is bound to be fetal effects, and these fetal effects are likely to be much more severe than what had happened in a prior pregnancy. So therefore, in these particular case scenarios, it makes every sense to actually skip all these lab-dependent tests that we spoke about, because all these are given in this particular pregnancy, and therefore you can straight away start monitoring for fetal anemia in this fetus by the ultrasound. When do you start monitoring? As early as 16 weeks of pregnancy, or 10 weeks prior to when the last fetus was affected, or the last pregnancy was affected, whichever is earlier. So now, how do you monitor the fetus for anemia on the ultrasound? Now, all of you would know for a fact that what we look at, or the parameter that we look at, is the peak systolic velocity in the middle cerebral artery. Now, why do we look at peak systolic velocities? Because we know that in fetal growth restriction, what we look at is the pulsatility index and the diastolic flow. But here I'm saying you should look at the peak systolic velocity. I'm sure most of you would know the answer to this. And the reason we look at peak systolic velocity is because you're talking about a fetus who is likely to be anemic. So when there is anemia, there are a couple of things that happen. Because of the hemolysis, this baby's RBCs would have got destroyed, and therefore the blood viscosity, which is contributed to a major chunk by the RBCs amongst the other blood cells, because there is a lot of hemolysis happening here, the blood viscosity is bound to be thinner. And we know for a fact that thinner the fluid, less viscous the fluid, higher would be the velocity of blood flow. And also, because the viscosity is reduced in these particular cases secondary to the hemolysis, there is increased venous return from the legs. Now, this would cause a hyperdynamic circulation, which would again push up the blood flow velocity. Now, the third reason is there is bound to be a little bit of hypoxia that is related to the anemia, which is called as anemic hypoxia. Now, anemic hypoxia, unlike the hypoxia that you attribute to placental insufficiency, is majorly compensated by the heart of this baby by increasing its cardiac output. Now remember, unlike in fetal growth restriction from placental insufficiency, the heart is not compromised here. The heart can therefore increase the cardiac output to compensate for the mild hypoxia that's going to be a result of this anemia in this baby. And that again results in a hyperdynamic circulation. So you have hyperdynamic circulation that happens from three reasons. One, decreased blood viscosity. Two, increased venous return because of the reduced viscosity. And three, because of the hyperdynamic circulation, because the heart is trying to compensate for the mild anemic hypoxia that's going to be there. So either which way you look at it, it is the blood velocity that's going to increase here, and which is why you're looking at the systolic velocity in the blood flow pattern and not the diastolic flow, because there is no hypoxia. Significant hypoxia is going to affect the brain and cause a redistribution of blood to the brain or brain sparing, and therefore there's no actual need to look at the diastolic flow, because there is no cerebral sparing or redistribution of flow, as we said in the case of fetal growth restriction. I hope it's clear. It's a little confusing, but I hope it's clear. Now, why do we look at MCA? Can I not look at the dorsalis pedis artery of this baby? Can I not look at the renal artery of this baby? Well, I can look at any particular artery or perhaps even the umbilical vein or another vein in the body of the fetus. But the reason we chose MCA is for two reasons. One, because this was the first described vessel in which the Mary's chart was based on. And second reason is because if you look at the Doppler equation, we said what we're trying to look for is the velocity, and velocity by the Doppler equation is inversely proportional to the cosine of the angle of insulation, of ultrasound insulation. So if I need to make the velocity independent of the angle of insulation, my cos theta has to be constant at 1. And if cos theta has to be 1, my theta, or the angle of insulation, has to be 0 degrees. And the middle cerebral artery has a unique property that in its anatomical position in which we scan for the middle cerebral artery, it gives you a natural 0 degree angle of inclination. Therefore, you would not have to be really bothered about correcting for the angle to measure the absolute velocity. Now remember, the MCA PSV is not just dependent on the angle, it's also dependent on the gestation age. Therefore, you need to convert absolute value of peak systolic velocity into what we call as multiples of median, so that you make it independent of the gestation age. Now, calculators are freely available for this. Most of these ultrasound reporting software that we use also have this facility to give you the MOM values if you key in the middle cerebral artery peak systolic velocity value. And if that's not available, you can always log on to the internet and look up at sites like perinatology.com, which will give you calculators where you can type the MCA PSV absolute value, and it will tell you what exactly the actual MOM value for that particular velocity is. Now remember, any MOM value that is more than 1.5 is what would tell you that this baby is severely anemic, specifically before you transfuse this particular baby. Now, God forbid, if you do not have access to any of these calculators or ultrasound reporting software, there is a rule of thumb that you can follow. If your peak systolic velocity absolute value is more than twice the gestational age of that particular fetus, then it's there's every likelihood that this fetus is indeed severely anemic. For example, if you have a 24-weeker and the blood flow velocity or the middle cerebral artery peak systolic velocity is above 48 centimeters per second, it is more than twice the gestational age, then you would know that this fetus is most likely anemic. And if you actually were to put in these values into a calculator, it would indeed turn out to be that this value is above 1.5 moms. Now, there is a possible error of 5 to 10% for the MCA-PSV. You could have a false positive or a false negative value, which is why it is very, very important to realize that you should always look at the trend in MCA-PSV value and not at just one-off value for that. Now, other than the MCA-PSV, there are signs that you could look for in the ultrasound to suspect fetal anemia. This could include placentalomegaly or placental thickness that's more than 4 centimeters. Specifically, if the placenta appears ground glass-like, as you would expect in a hydropic placenta, which is edematous. You could also, if you're specifically looking for it, see hepatosplenomegaly, because we know that when there is fetal anemia, there is extramedullary hematopoiesis that happens, and therefore there is bound to be some hepatosplenomegaly at some point during the gestation. You could also notice polyhydramnios in some of these cases, because we said when there is a hyperdynamic circulation, there is an increase in the GFR. And when there is an increase in the GFR, the baby puts out more urine as a compensation mechanism. And therefore, the amniotic fluid value also tends to be higher in these babies, particularly later on in pregnancy. Now, the other end of the spectrum, if this baby has indeed gone in for cardiac failure and hydrops, you would see, as the definition of hydrops goes, you would see fluid collection in more than one body compartment, as is seen in this particular picture. Now, when do we start fetal monitoring for anemia? As I said, if there is a previously affected fetus, you would start 10 weeks prior to that event or 16 weeks, whichever is earlier. If there has been no prior affected pregnancy, you would start monitoring closer to 20 weeks of gestation. Interval between two scans is arbitrary, but would depend on the individual case scenario and the severity of that particular case scenario, but can be anywhere between 1 to 2 weeks and is best left to the discretion of the consultant who is handling the particular case. So now, how do we manage this pregnancy based on the MCA-PSV value of the fetus? Now, if the MCA-PSV value is below 1.5 moms, which we said is the cutoff for severe fetal anemia, you can push this pregnancy by serial monitoring and deliver this lady as late as term, 37 to 38 weeks. But if, on the other hand, the MCA-PSV mom value is above 1.5, it tells you that this baby is severely anemic. Then you look at the gestational age. If she's already crossed 35 weeks, you can deliver her without a doubt. But if she's below 35 weeks, that is the indication for a fetal intervention in terms of an intrauterine transfusion to try and rescue this fetus from the effects of alloimmunization or hemolysis. Now, I promised to mention to you the 15-step approach to doing an intrauterine transfusion. We will quickly go through this. And the 15 steps involved here are those that you see on the screen now. We will quickly discuss the relevant ones in these 15 steps. We will, of course, start with preparing blood to transfuse to the fetus. Now, the blood that you give to the fetus has to be cross-matched. Now, cross-matching has two implications. In most common settings like ours, this cross-matching is restricted to matching the donor's blood with the mother's antibodies. In other words, you assume that the mother's antibodies would cross over to the fetus and would be there in the fetal circulation as well. Now, if the blood that you give is incompatible to this, and you transfuse that blood to this fetus, these antibodies would destroy the blood that you give, and therefore would negate the effect of your intrauterine transfusion. Now, that is what cross-matching entails in our setting. But if you look at more advanced centers, particularly those Western centers that we keep looking at, they would go one step further. They would also cross-match the sample of the donor and the maternal blood sample to make sure that you do not introduce new antigens that the mother is not already sensitized to. Now that requires a lot more of testing, a lot more elaborate testing on the donor sample, and therefore the costs are going to be significantly higher, which is why we do not routinely do that in our setting. So cross-matching, for all practical purposes, in our setting, is to prevent hemolysis, further hemolysis of the blood that you transfuse into the fetus. Full stop. Now, if the antibody that is involved here is the D antibody, the blood that we use to transfuse, or the blood that we choose to transfuse, the donor that we select to transfuse has to be an O negative donor, because we said we do not want to introduce new antibodies in the circulation as far as possible, even if you don't do a cross-matching in that regard. Now, if it is a non-D antibody that we're looking at, then the blood that you need to give has to be type specific for that particular antibody that is involved. We would also require the lab to do an infection screening for the common infections, particularly HIV, HVSAG, and hepatitis C. Also, the TORCH group of infections, which are notorious to cause fetal effects. We would ideally request for a blood that is less than 7 days old. The reason being, the longer the blood stays in the blood bank, the lesser is going to be the amount of 2,3-DPG or diphosphoglycerol in that blood sample, in the blood bag. What we want is a high level of 2,3-DPG, because we know for a fact that higher the level of 2,3-DPG, greater is the oxygen dissociation curve shift to the right, which means if you have high amount of 2,3-DPG in the blood that you give, more is the amount of oxygen that is released to the fetus, which is why we need as fresh a blood sample as you can get. Now, we would also request the lab to do a gamma irradiation of the blood that is given to the fetus, and this is to prevent the fatal complication of graft versus host disease. The last thing that you would do is a leukodepletion. You would want to rid this blood of WBCs, the white blood cells, the leukocytes. The reason being, CMV virus, which is notorious to cause problems in the fetus, anomalies in the fetus, growth restriction in the fetus, rides piggyback on white blood cells. So if you clear the blood that you give of the leukocytes, the white blood cells, you are making sure that you do not transmit CMV to the fetus, even if the donor is CMV infected. One more step before you give to the fetus is to pack the red blood cells. You do not want to be transfusing whole blood, because the volume that you would then require is going to be much, much higher. You're transfusing blood to a fetus that is already overloaded because of the anemia and the hyperdynamic circulation. You do not want to be pushing in too much of blood volume and further compromise the baby's heart or the fetus's heart. Therefore, you would need as high a hematocrit as you can transfuse. Generally, we ask for a hematocrit of the donor above 80 or 85%. Anything above 75% can work without a problem. Now, this is what they call as packing of the blood. So the blood is packed to a hematocrit of 85 or 80 or 90, sometimes even 92, 93 we get. So which means you can minimize the amount of blood that you need to transfuse to the fetus. So this is about blood preparation. If we talk about maternal preparation, it is wise to give steroid cover, antenatal steroids to the mother 48 hours before transfusion if she's crossed 26 weeks, should there be a immediate delivery that you need to do for some reason, or if she goes into preterm labor. It's preferable that you avoid a big meal before within 4 to 6 hours before a transfusion, because the mother would be much more comfortable on the couch if she's not had a heavy meal prior to that. It's always mandatory that you have an IV access, because at times things could go wrong. There could be a problem where you would need to put in an emergency drip or a transfusion to the mother. She could have hypovolemia, she could go into shock, all sorts of things could happen. Therefore, it's always preferable in fact, mandatory that you have an IV access before you start the intrauterine transfusion. If you ask me about antibiotic prophylaxis, well, there is no evidence to recommend routine antibiotic prophylaxis before you give an intrauterine transfusion, assuming that you take all aseptic precautions. Maternal sedation, again, is optional. You can give if you have an anesthetic standing by, if you're doing it in the theater, but otherwise, a local anesthetic is far more than sufficient in such cases. Now we come to the setting for an intrauterine transfusion. As far as where you do a transfusion, you could do it in an OP basis, in an OP setting, provided you have an emergency card should something go wrong. But it's always safer and recommended that you do an intrauterine transfusion in a double setup, meaning either in the labor room or in the theater, because if there is an emergency, if there is a complication like persistent bradycardia that happens and you need to deliver this baby immediately to try and save the fetus's life, then it's always safer that you are operating or you are transfusing in a double setup. Now, the setting that you would need in the place where you do the transfusion is to have a couch for the patient to lie on. You would need a good quality ultrasound machine with Doppler facility. You would need a tray to keep all your samples or to keep all your tubings and gadgets ready. You would need a table to keep the hemometer and a place to do all your calculations to calculate how much of blood needs to be transfused to the baby. You would need a drip stand or an IV stand to hang up the blood bag so that there is blood flow that's aided by gravity. Remember, you're giving very high hematocrit or a high concentrated packed red blood cells. So the flow of blood is going to be very, very slow. So it always helps to have a little bit of gravity assisting you on that account. You would, of course, need the person or the doctor who's going to do the transfusion and at least one assistant. You would also need a scrub nurse to give you all the stuff that you would need to do the transfusion from time to time. So this is the setting that you would need. Now, coming to the set that you would need for the transfusion, I've arranged this in this particular tray in the order in which you would need these during the transfusion. First, of course, you would need the paint set to paint and drape the mother. You would then need the 22-gauge spinal needle to give local anesthetic and muscle relaxant to the fetus before you do the transfusion. The next thing that you would need is a paralytic agent, which could either be one of several agents, which we would discuss in the next step. You would need a blood transfusion set, one end of which would go to the blood bag, the other end which would go to the transfusion line. You would need a 10 milliliter syringe because remember, it is not a direct transfusion from the blood bag to the fetus. Every milliliter of blood that you give to the fetus has to be measured because you would want to know how much you've given to the fetus. You would also have calculators telling you how much needs to be given to the fetus. So it's always advisable that you have a syringe and you give blood in a very, very measured fashion and not run the line straight from the blood bag to the fetus. You would also need a three-way, one end of which is connected to the blood bag, the other end connects to the fetus, and the third way is connected to the 10 ml syringe where you draw the blood and push it to the fetus. You draw blood from the blood bag to the 10 ml syringe, and then turn it around and transfuse that to the fetus as you measure it and transfuse. You would also need another 10 ml syringe for local injection to the fetus, to the mother, to numb the mother's skin and subcutaneous tissue. And then is the most important needle of the lot, which is the 20-gauge Chiba needle, which is used to do the actual transfusion. This is the needle that goes into the vascular access that you get to transfuse the baby. You would also need additionally 2 1 milliliter syringes, one to do the initial fetal blood sampling to know the fetal hematocrit, and second, to actually flush the tubings and the needle if required, and to draw a fetal sample at the end of the procedure, and maybe in some cases to draw heparin to flush the tubing. So you may need 1 or 2 1 ml syringes additional to this. You would then need a kidney tray to discard all the tubings and the needles which you have used and thrown. And you would also need a set of gauze pieces and gloves to actually perform the actual transfusion. What I've missed out here is some normal saline or distilled water. which you would need to flush the tubing if that is required as well. Now, the first step before you begin the transfusion is to flush the needle and your tubings with heparin so that there's no question of blood clotting inside the needle or the tubings. You would then load pancuronium, which is the muscle relaxant that we generally use. 0.5 ml of pancuronium is diluted with 0.5 milliliters of distilled water, and then the dose that you need to give will be discussed subsequently. You constitute the solution of 1:1 strength, as I said. Take 0.5 ml of pancuronium and 0.5 ml of distilled water, and this constitution will give you a 1:1 strength of pancuronium. Now, once you've kept all this ready, you paint and drape the patient, as you can see in this picture, and this is how this setting would look once you've done the painting and draping. And then comes the most important step of choosing the right axis, because this is a very, very important step. If your axis goes wrong, then the whole procedure goes wrong. So take your time and choose your axis. You have 4 options to choose from. You could either do an intrafunicular transfusion, where you transfuse into the umbilical cord, preferably into the umbilical vein. You could either transfuse into the intrahepatic portion of the umbilical or the portal veins. In some cases, you might need to give an intraperitoneal transfusion, and very, very rarely, you may need to transfuse directly into the fetal heart. Now, which of these to choose depends on the individual case scenario and the individual consultant who is doing the procedure. Depends predominantly on what you're comfortable doing and what you've grown up seeing your teachers do. Both of the umbilical vein route into the cord or the portal vein route into the intrahepatic portion of the portal vein are equally acceptable. As I said, it is more often than not a question of individual choice rather than anything else. Now then, after you've done that, you assess the fetal position and you plan a route of entry. Look at the availability. You take time in planning your entry because, as I said, this is the most crucial step. You measure the depth at which your target is, even if it's a portal vein or the cord insertion site. Very rarely, you might need to choose a free loop of the cord as well if you don't have access to either of the other 2 sites. So once you're sure of once you're sure of your fetal entry, then you decide to go in and give fetal paralysis before the position moves. Now, fetal paralysis is a debatable option here. There are experts who do not give a fetal paralysis unless you choose to do a transfusion with the free loop of the cord. But we are more comfortable giving fetal paralysis, particularly if you're transfusing into the intrahepatic portal vein, which is the most common route that we prefer to go into. Now, you give 0.4 milliliters of pancuronium, generally for a fetus that is in excess of, that has crossed 30 weeks of gestation. If it's below 30 weeks, you would give 0.2 to 0.3 milliliters of that 1:1 diluted strength of pancuronium. You could also give vecuronium in the same 0.1 milligrams per kilogram estimated fetal weight dosing. The other short-acting alternative that you could do, if you're sure you're going to complete the procedure in less than half an hour to 1 hour's time, you could choose the shorter-acting atracurium, because that would not cause the mother to not appreciate fetal movements for a much longer time after. If you give pancuronium or vecuronium, the mother would not probably appreciate fetal movements till around 3 to 4 hours after the injection is given to the fetus. Whereas if it's atracurium that you give, you can appreciate fetal movements. The mother can appreciate fetal movements as early as half to 1 hour after you've given the dose. Now, the question of analgesia to the fetus is again debatable, because there is this argument that the fetus does not feel pain before 30 to 34 weeks of gestation. But if you do indeed choose to give analgesia, the drug of choice is fentanyl, and the dose is 2 micrograms per kilogram. Now, once you've secured fetal paralysis, you would get some time after you've given the injection and before the fetus settles down. You can wisely use the time to set up the transfusion line. Now, how you do this, as I said, is to connect one end of the blood transfusion set to the blood bag, which is what your scrub nurse is doing here. The other end, and then she would hang it up, as I said, onto the transfusion stand or the drip stand. The other end of this goes into the 3-way or the 3-way extension, and you can see that the other end of the 3-way is connected to the fetus or to the line that would go to the fetus, and the third part is connected to the 10 milliliter syringe to which you would draw the fetal blood. Once the transfusion line is set and you get a free flow of blood at the end that is to go into the fetus, you decide to enter the fetus with the needle. Again, of course, first step is to give infiltrate local anesthesia. You raise a wheel on the maternal surface and then anesthetize the maternal skin and subcutaneous tissue, which is what you see in this particular video. I skipped that. And once the mother has been adequately anesthetized, you enter the fetus with the 20 gauge Chiba needle. Now you've already planned your entry before. Hello. Hello.
Hello, doctor.
Yes, is there a problem?
Yeah, there was suddenly screen got stopped.
Okay, so let's just screen sharing.
Yeah, it's now on. Now on.
Now on.
You can directly open the presentation here.
Is the slide back?
Yeah.
Okay. So sorry for the hitch. Can I continue, Harish? Hello.
Continue, doctor. Continue.
Okay. Right. So now we said the first step, the most important step again, is to do a fetal blood sampling. So now you're inside the vascular stream of the fetus, and you would want to draw 1 milliliter of fetal blood or a small sample of fetal blood to assess the initial fetal hematocrit before the transfusion. This is what is going to tell you how much of blood you need to transfuse to this fetus, and which is for what you need the hemometer. So you give it to the technician who would do this for you, and then the technician will tell you what is exactly the starting fetal hematocrit. Now, once you know the fetal hematocrit, now you remember you would also draw a little bit of fetal blood to send for serum bilirubin, to send for the baby's blood group, because the only time that you can know the baby's blood group for sure is before you do the first transfusion. Once you've done the transfusion, the blood group is always going to be O negative, even after delivery. So remember, this is the only chance for you to assess the actual blood group of the baby. So make sure while you draw the blood for sampling, while you draw the blood to know the fetal hematocrit, you should also draw a little more blood and ask your scrub nurse to send that for fetal hematocrit again from the main lab, the central lab. You would also send for DCT or direct Coombs test. You would send for a serum bilirubin and even a reticulocyte count, and for blood grouping and cross matching, for blood grouping and RH typing. So this is the set of 5 tests that you would want to do on the first sample or the first blood that you draw. Now, once you know the initial fetal hematocrit, comes this daunting task of calculating how much blood you need to actually transfuse to the fetus. Now, how do you calculate this? Now, it depends on what route you choose to give. If it's assuming that you choose to give intravascular transfusion, the volume of blood that you need to give would depend upon the initial fetal hematocrit, the fetal-placental blood volume, because this blood is going to go into the fetal-placental circulation. You need to know the donor hematocrit, which of course a blood bank that supplied the blood bag would tell you. And remember that the target hematocrit that you generally would aim to achieve is around 45 to 50, even though there are advocates for a slightly higher target hematocrit as high as around 55%. But generally, for most clinicians, most specialists, they would choose to go for a target hematocrit of around 45 to 50%. Now, whether or not you need to split this transfusion before 24 weeks is again debatable, but we generally do not split up our transfusions. We give the whole calculated volume in one sitting. And again, as I said, supraphysiological transfusion means transfusion to a target hematocrit in excess of around 50 Or 55% is generally not advised because this can lead to a marked rise in blood viscosity and can potentially cause thrombotic events in the fetus. So you would not want to push up the target hematocrit to above 55 in any case. Safer conservative target would be around 45 to 50%. Now, there are several methods by which you can calculate the amount of transfusion of blood that needs to be transfused. There are people who use the Mary's chart or the transfusion coefficients. There are some people that use a formula for calculating the volume of blood. Or there are, as I said before, with the calculation of MCA-PSV mobs, you have calculators that are freely and widely available on the internet, which will tell you if you key in the hematocrit of the donor and the fetal hematocrit, what is the and the estimated fetal weight. It will tell you exactly how much of blood needs to be transfused. There are also, as I said, methods like the transfusion coefficient, which will tell you the factor, the coefficient factor by which the estimated fetal weight can be multiplied to get the target increase in fetal hematocrit that you want. For example, if you want to increase the fetal hematocrit by 15 percentage, you would need to multiply the estimated fetal weight by a transfusion coefficient of 0.03. Now, these are again reasonably okay methods to go by. There are also thumb rules that some people go by, which goes something like this: for every 1 gram rise in fetal hemoglobin, you would roughly need around 10 ml of packed red blood cells. Now, this again can vary depending on if it's before 28 weeks, it's 9 ml. If it's after 30 weeks, it's 13 ml, and so on and so forth. But a rough estimate, if you get a target, if you get a donor hematocrit of 75%, would be to use 10 ml of packed red blood cells for every 1 gram rise in fetal hemoglobin. But having said that, with calculators and with the internet being freely available even on all smartphones these days, it's always more objective to go for a calculator that is available on the internet rather than going by a rule of thumb. Now, once you've actually calculated how much of blood needs to go into the fetus is when you start the transfusion per se. Now, the setting, as I said, is you draw blood from the blood bag into the 10 ml syringe, close the blood bag end, open the end that is connected to the needle, and then transfuse that measured quantity of blood into the fetal circulation. This is how it's done. As you can see here, I'm now drawing blood from the blood bag. This three-way is now open to the blood bag end. I'm drawing blood from the blood bag. I can make sure that I'm drawing blood from the blood bag by looking at the blood bag itself and seeing a sudden stream of blood into the collector there. Now I draw 10 milliliters of blood. I make it a point to hold the tube vertical so that if there's any air in the tubing, that would go up and would not be pushed back into the fetus. Now I turn the three-way knob around and then I measure as I give this blood to the fetus. So if this 10 ml is given to the fetus, I ask my scrub nurse to document that I've given 10 ml, and then I repeat the whole thing again, turn this knob around and then start aspirating from the blood bag, turn it again further, and then give it back to the fetus. So that's how the cycle of transfusion goes. And once you've done that, it's always a very, very pleasurable sight to see this cascade of blood that's flowing into the fetal circulation. You realize that finally I'm doing something to try and save this baby from dying out of hemolysis and cardiac failure. Now, what are the complications of an intrauterine transfusion? Generally, inexperienced hands, the chances of a complication is extremely low. It's generally a very, very safe procedure. The overall complication rate being as low as 1%. The most common complications that you would expect is bleeding and bradycardia. So it is always a safe practice to keep looking at the baby's heart to document that there are no persistent episodes of bradycardia, which could be detrimental and which could lead to a cardiac arrest if you're not aware of it. So one thing that you can do is, if you're transfusing into the intrahepatic portal vein, you can look at the cross-section of the descending aorta that's going to be there besides the spine, and you can appreciate the aortic pulsations. You need not keep going back and forth to the fetal heart. You can make it a practice to keep looking at the aortic pulsation in the same cross-section of the intrahepatic portal vein, and that will tell you if there is a bradycardia or not. The other less common complications include infections, PPROM, and fetal loss, but these are all extremely rare, specifically if it's an experienced person handling the transfusion. Now, once you've completed your transfusion, you would do a sampling again to know the closing hematocrit. This is as important as knowing the initial hematocrit, because this closing hematocrit is what is going to determine whether or not you need a fetal transfusion, and if you need one, when would you need this transfusion. So timing a second or a third transfusion is going to depend on this final hematocrit and the rate of foreign hematocrit that you would expect from there on. So it's very, very important to get a fetal closing hematocrit value as well. You would also want to document that you've done good to this fetus by documenting a fall in the middle cerebral artery, peak systolic velocity. Now, this is most often seen immediately after the transfusion, but in some cases it might take a little while. So do not be unduly panicky if you don't see a foreign hematocrit, foreign MCA-PSP immediately after your transfusion. But generally, as soon as you finish your transfusion, the MCA-PSP do tend to fall. And if you know how to do it, it's always good to do a myocardial performance index to know how the heart is compensating with all the blood volume, extra blood volume that you push into the circulation. And then comes planning a subsequent transfusion. This, as I said, is based on the closing hematocrit after your first transfusion and on the expected fall in hematocrit after the first transfusion. Now remember the rule that after your first transfusion, the expected rate of fall in hematocrit in hemoglobin is 0.4 grams per deciliter. After your second transfusion, it's 0.3 grams per deciliter per day. And after the third transfusion, you would expect the hemoglobin to fall at the rate of 0.2 grams per deciliter per day. It's easy to remember, 0.4, 0.3, 0.2. If it's hematocrit that you're dealing with, it's 3 times this. So 1.2, 0.9, and 0.6 percentage fall in hematocrit per day. Now, remember that the MCA-PSV is not as reliable as it is in predicting fetal anemia as it is before you've done the first transfusion. The reason is the moment you've pushed in blood by an intrauterine transfusion, what you're pushing in is not fetal blood, but adult blood from an adult donor. The rheological properties of the red blood cells of an adult are completely different from that of a fetus. The dimensions, the size, the viscosity, the thickness, the blood flow, speed, everything is going to be different after you've done the first transfusion. The stickiness of the blood is different, and therefore the middle cerebral artery peak systolic velocity would not be a reliable indicator of fetal anemia after you've given the fetus one transfusion prior. Now, there have been studies that have suggested using a slightly higher cutoff of 1.7 moms rather than 1.5 moms to do your second transfusion. There are studies that have also said you can use a cutoff of 1.9 moms for your third transfusion. However, this is debatable, as Dr. Pratima and her group from BFMC has proven in this very recent paper. If you choose to use 1.7 rather than 1.5 as a cutoff, there is a risk that you run. This risk is that you could miss out on 1/3 of the fetuses that would actually require a second or a third or a fourth transfusion if you choose to increase your cutoff from 1.5 to 1.7. So they say that you would rather stick to this cutoff of 1.5 for timing even the second transfusion. But having said that, most centers would generally prefer to go by this as well as the falling hematocrit method that I just described in the previous slide. Now, the last thing to know of the 15 steps is once you've done the transfusion and corrected the fetal anemia, how and when do you plan delivery? Now, our protocol is generally to time the delivery of this mother 3 weeks after the last intrauterine transfusion. Preferably, we time our transfusions in such a manner that you give the last transfusion at around 34 weeks or 35 weeks, between 34 and 35 weeks, and then deliver this lady at term after 37 weeks of gestation. Method of delivery, we've taken her to term. There is no reason to do a cesarean section just because of the fact that you've done a transfusion prior. These babies can withstand the stress of labor if you've corrected the anemia. Therefore, you at every chance that you can offer her labor induction, provided you've corrected the anemia by a prior transfusion. Now, also remember that a well-planned and well-timed intrauterine transfusions, as I said, can obviate the need for a preterm delivery. As I said, if you transfuse her at around 34 to 35 weeks, you would buy another 3 to 4 weeks time before the baby goes into severe anemia again. Therefore, you would have every opportunity to deliver her as close to term as possible. Now, the last part of this webinar would deal with the management of the neonate. I would spend a little bit of time on managing on the management of the neonate as well. And I must acknowledge the contribution of my colleague, Dr. Ashwin, for having enlightened me on the management of the neonate. To Dr. Lakshmi as well, both of them given invaluable inputs on the management of the neonate of an isoimmunized mother pregnancy. Now, the first thing we need to understand is that with intrauterine transfusions becoming very widely available in a lot of centers practicing intrauterine transfusions and correcting fetal anemia, the good thing that has happened is that the overall perinatal mortality in severe hematologic disease that is related to rhesus incompatibility has decreased significantly to as low as 10% these days. Now, the main focus in the management of the neonate is not the treatment of anemia as we would expect, but the mainstay has to be, and the main focus has to be on the treatment of hyperbilirubinemia and prevention of kernicterus, because this is far, far more dangerous a proposition than early or late fetal anemia. Now, the reason is if there is a very high level of bilirubin, this bilirubin can cross the blood-brain barrier. And once it crosses the blood-brain barrier, this bilirubin would settle down in different parts of the brain with a particular affinity for the lentiform nucleus or the internal capsule, as you can see in this particular picture. And depending on where this excess bilirubin gets deposited on the brain, you could have one of several clinical features, including extrapyramidal symptoms, oculomotor paresis, hearing loss, unsteadiness of posture, and so on and so forth. And this is a very, very deadly situation because once this baby reaches kernicterus, it reaches a point of no return. Therefore, it's very, very important that you prevent kernicterus at all costs in a fetus that has been isoimmunized. Now, having said that, if you discuss this with neonatologists, they would tell you that recently, if you look at the progression of hyperbilirubinemia to kernicterus, there is a staged progression, and in between hyperbilirubinemia and kernicterus at the other end, you have a specific stage that neonatologists refer to as bind. Now, bind refers to bilirubin-induced neurological dysfunction. Now, this is an intermediate step between hyperbilirubinemia and kernicterus, and as far as I have figured out, the difference between bind and kernicterus is that bind is a reversible phase in this progression, but kernicterus is the end stage of chronic bilirubin encephalopathy, which once reached becomes irreversible and permanent. So if you manage to pick up a fetus in the stage of bind or bilirubin-induced neurological dysfunction by the classical clinical features like lethargy and weakness and so on and so forth, you have every chance of reversing this natural history and preventing this baby from going into kernicterus. So bind is a phase that has been recently identified, and it's very important that your neonatologist identifies this fetus in this phase at least before it goes into irreversible kernicterus. Now, the reason they say that bind is reversible is because the hemodynamics and the pathophysiology of how bilirubin leads on to kernicterus has turned out to be a far more complex procedure or a phenomenon than what was thought in olden times. And to understand this, we need to understand this pathophysiology in a little bit. To make it very, very simple, we need to understand that bilirubin in the fetus, or in any human being for that matter, exists in two forms: the bound form and the unbound form, or the free form. Now, the protein that binds bilirubin is albumin, as is the case with most protein binding substances in the body. And what we need to understand is that the bound fraction of bilirubin, or the bilirubin that is bound to albumin, will not cross the blood-brain barrier and would only stay in the fetal circulation, whereas it is the unbound form, or the free bilirubin, that's going to cross the blood-brain barrier. Now, unlike what was thought in olden times, 1 gram of albumin, 1 gram per deciliter of albumin, can bind to not 1 but 8 milligrams per deciliter of bilirubin. Now, so if you're looking at a fetus that has got 3 grams per deciliter, which is the expected normal albumin level in any fetus, this fetus can retain up to 24 milligrams per deciliter of bilirubin in its circulation. And without letting this bilirubin enter or cross the blood-brain barrier. Which is why neonatologists these days are far more tolerant to higher levels of bilirubin than in olden times. Now, remember, there was a time when neonatologists would give exchange transfusion to a fetus as soon as the bilirubin shot up above 5 milligrams per deciliter. But today, they would wait to as high as 20 milligrams per deciliter before they decide to give the fetus an exchange transfusion. So therefore, the procedure, the management of choice these days is not exchange transfusion, but intense phototherapy to try and reverse the natural history of hyperbilirubinemia from progressing to cardiac arrest. So intense phototherapy in most situations can reverse the hyperbilirubinemia, and you would resort to exchange transfusion as a last step, even if despite intense phototherapy and despite in some cases IV immunoglobulin, the baby runs a risk of cardiac arrest because the bilirubin goes above 20 milligrams per deciliter. Now, this magic number of 20, or the fear of 20, is what neonatologists refer to by a very fancy term called viginitophobia. So that means that they are scared of the number 20. If the bilirubin goes above 20, is when they would start thinking of a exchange transfusion. Now, anemia is also a concern. It's not that anemia in the neonate is not a concern, because we need to understand that the antibodies that have crossed from the mother can continue in the fetal circulation for up to 3 months after birth. So these antibodies can still continue to cause fetal hemolysis, neonatal hemolysis and anemia. And therefore, you might need to top up, especially if you've done a transfusion. All you might need to do is to top up for correcting the early anemia that is there. And remember, while you transfuse or decide to give a top-up transfusion, our goal is to keep the neonate asymptomatic and not to correct the entire hemoglobin deficit, because if you correct the entire deficit, that might suppress erythropoiesis in the neonate, which is not what you want. You want the baby to be actively undergoing erythropoiesis, so that can improve the number of red blood cells that are naturally there in the fetal circulation. Therefore, keep maintaining some amount of anemia, modest anemia, so that erythropoiesis continues to be driven. But you have to ensure that the baby has sufficient amounts of hemoglobin so as to not be symptomatic. And once a reticulocytosis is noted, that is a sign of erythropoiesis, and that is when you can actually stop considering future of your further transfusions in that particular neonate. Now, as I said, antibodies could persist up to 3 months, and therefore, even if you discharge this baby from the hospital, there is every chance of a late anemia happening. And remember, it is not easy for the parents to pick up anemia in a baby, in an infant, because the baby would not show any particular clinical sign of anemia. It would be active, it would be playful until and unless the very last stages of anemia, when it starts to have cardiac failure, and then of course it would be too late to do anything. Now, which is why for every presentation that I make on this particular topic, I keep reminding the audience of this, one of our very first intrauterine transfusions that we did. This was a very precious pregnancy. This baby had a prior loss due to RH incompatibility and fetal anemia and cardiac failure. She came to us in this pregnancy. We successfully corrected the anemia by a couple of, I think, 2 or 3 transfusions. The baby was delivered at term, was hale and hearty and healthy, just needed 1 top-up transfusion after birth. We discharged her, very clearly advising her to come back for regular follow-ups as advised by the neonatologist. But for some reason, they never came back. They never heeded to our request for follow-up. Despite warning them that there could be late anemia, this baby was not brought back to us for regular follow-ups after delivery. And then one fine day, they come rushing to the hospital, by which time the baby was in severe cardiac failure. And despite the best efforts of our neonatal team, we could not save this baby. Now, so all those 3 transfusions, all those management, all those tests that we did in the baby, and all the effort we did to try and save this baby from dying went in waste just because the patient was not compliant to our request to come back for follow-up transfusion. Now, this was a classical case of late anemia. The parents had no clue that this baby was anemic. It went into cardiac failure, and that's when it stopped feeding. That's when it stopped becoming active, being active, and that's when they brought this baby to the to the hospital, by which time things had gone completely out of hand. So remember, you need to discharge your babies on a very clear advice protocol as far as postnatal management is concerned. This baby has to be monitored till proper reticulocytosis is documented and for at least 3 months after delivery. So I think with that, we come to the end of this exhaustive and long webinar. But as I said at the beginning, there are still a few of those 6 cases that we discussed that have still not been solved. So I'll try and solve them and sort them out for you. Now, the first case that we discussed of the 24-year-old primey who had an ICT positive. Now, why would a primey gravida have a positive ICT? It means she has had some exposure to some foreign antigen at some point in her life thus far. But I clearly said that she's not had a history of blood transfusion. So what else could be a sensitizing event in this pregnancy? Now, if you remember, as somebody had asked a question in our last part, this lady had a history of dengue fever for which she had received mismatched platelet transfusion in an emergency. She had been transfused with 13 or 14 bags of platelets, and because it was an emergency, cross-matching was not done, and unfortunately, nobody realized that an anti-D has to be given if you transfuse mismatched platelets, and this mismatched platelet transfusion is what resulted in a positive ICT in this primary gravida. Now, we clearly discussed case 2, so we will jump to case 3. So case 3 was a second gravida, negative positive couple, where despite the anti-D being given, this lady tested ICT positive in this pregnancy. Now, this is a very, very clear case of anti-D failure. We had elaborately discussed this in the part 1 of this webinar. We said anti-D failure is not an uncommon phenomenon. I hope you remember Gerard Wies's paper that said that 50% of mothers who need anti-D in the world are not being given anti-D, either because of errors of omission or because of errors of commission. So we would not discuss in detail on that. We would not go back into details of that, but this is very clearly discussed in the last webinar. We discussed case 4 again prior, so we would now jump to case 5. Now, this was a case of that lady with systemic lupus erythematosus, where despite the entire family being negative, the baby was ICT positive. The reason the ICT was positive in this pregnancy was because she had autoantibodies in her circulation. Remember what we said before? It's not just alloantibodies that can cause a positive ICT. Any antibody in the mother's blood can cause a positive ICT. And in this particular case, it was the autoantibodies of systemic lupus erythematosus that was responsible for the positive ICT, despite the family being rhesus negative. And the last case that we discussed was the primary gravida, where the ICT was negative at booking, but positive at 30 weeks. Now, this was a case where routine anti-D prophylaxis, antenatal anti-D prophylaxis was practiced, and therefore she was given anti-D at 28 weeks. And as we very clearly mentioned last time, if you give anti-D at 28 weeks, the ICT would be positive for 4 to 6 weeks, or sometimes even up to 12 weeks after your antenatal dose of antepartum anti-D, and therefore that was why this lady showed a positive ICT. But remember, as we said last time, the titers would never exceed 1:4 in the tube method following an anti-D that you give as part of your anti-D prophylaxis, unlike in case of an immune anti-D. So those were the 6 cases, and those were the answers to those 6 cases. So I would finally conclude with take-home messages, rather take-to-work messages. There are no take-home messages because all of us are sitting at home and listening to the webinar. So these are messages that you would want to take to work from tomorrow onwards. Now remember that ICT positive is not the end, but just a starting point. There are a lot of implications to a positive ICT, as we very clearly discussed during the entire course of this lecture. It is equally important to understand the different methods that you use to do ICT titers. Remember the difference between the tube titers and the gel titers. Remember the gel titers are the most commonly done in most labs these days because it is easier to do, and gel titers would always show higher values than the tube titers. So if you're following the gel titer and trying to manage with a critical titer for the tube method, you could go awfully wrong in your management. It's also important to know the concept of the critical titer, specific to your lab, specific to your method. So ask your lab, ask your hematologist, ask your transfusion medicine expert, what is our critical titer, what is the method that which by which we do the titers. So make sure that you know the critical titers specific to that lab and to that particular method. We discussed gel titers are 3 to 4 times higher on an average. And the critical titer, if you are to go by our study that we did at our center, the critical titer for gel method is 1 in 64. You can use that as a rough estimate in other centers as well, unless you have more data coming in on this. And if the titer goes above critical titer is when you need to start following this baby up for fetal hemolysis and fetal anemia. The key in management is to identify anemia early by middle cerebral artery peak systolic velocity. And once you understand that there is fetal anemia, severe fetal anemia as evidenced by an MCA-PSV mom of more than 1.5, then is the time to think of an intrauterine transfusion. We spoke at length about the 15 steps of the intrauterine transfusion when the MCA-PSV goes above 1.5. And we also looked in detail at the management of the neonate, where we said the focus is on management of hyperbilirubinemia and prevention of kernicterus, and also to a lesser extent to try and minimize the risks of the baby being symptomatic from either early or late anemia. But never overcorrect anemia in the neonate because you do not want to suppress reticulocytosis or erythropoiesis. Therefore, keep a modest anemia, but make sure that the baby does not go in for cardiac failure. Thank you for a very patient listening. I know I have exceeded all time limits and time constraints, but I had to convey these messages to you, and I thank all of you who have stayed till the end to listen to this. Thank you very much. I would come back on and stop sharing my screen. So Harish, I think we'll quickly take a few questions because there are quite a few questions coming in, I think. I don't know why my camera is not switching on.
We can hear you, doctor. So I think it will come automatic. Yeah, we can continue with the Q&A.
Okay. So yes, so elaborate teaching. Okay. So the first question is, if a woman is ICT positive and has a previous unaffected pregnancy, is the management any different? Okay, so that is a very good question. So we spoke about a mother with a previous affected pregnancy. We did not speak about a mother with a previous unaffected pregnancy. So thank you for bringing this point up. Now, if you're thinking in terms of a prior unaffected pregnancy, what we would need to know is why was this prior pregnancy possibly unaffected? Now, the reason the first pregnancy would have been unaffected was because either the baby was negative for that particular antibody, of a particular antigen, or the titer would have been low. These are three reasons why the pregnancy could have been unaffected last time. Now, my question to you is, does any of these reassure you in this present pregnancy? Because if the baby was negative in a previous pregnancy, the baby could well be positive in this pregnancy. So that is not a reassurance. Now, the other reason why she would not, the previous pregnancy would not have been affected is probably because the titers were low. Now, does that guarantee you that the titer is going to be low in this pregnancy? No, because as we said in the last part of the webinar, the titers constantly keep increasing with every successive pregnancy. Now, the third reason the previous pregnancy would have been unaffected was because probably the antibody would have been a weak antibody, maybe a group 3 antibody. But again, in this pregnancy, there is no guarantee that it's going to be the same antibody because she would have probably developed sensitization to a new antibody, to a completely different antibody, maybe a group 1 antibody in this pregnancy. So none of the reasons that could possibly have led to the first baby not being affected hold good in this pregnancy. And therefore, for all practical purposes, even if there is a prior pregnancy that was unaffected, I think you should manage this pregnancy as a case of a first alloimmunized pregnancy. I hope I make some sense. Okay, so second question. We never do an ICT if both husband and wife are rhesus negative. Is it a wrong practice? I would have to say that it is indeed a wrong practice because, as I said, paternity is not always what is stated. As I said before, the biological father of this pregnancy need not be the legal husband of this lady. That's one reason. Now, the second reason is it is not uncommon for a lady to have a prior undisclosed pregnancy. Now, she might be negative, the husband also might be negative, but we never know whether she's had an undisclosed pregnancy from another positive partner. Now, we know that 90% of the population is rhesus positive. So if she's had a pregnancy from an undisclosed partner and an undisclosed pregnancy prior and has undergone a medical termination of pregnancy for which anti-D is less likely to have been given because she would have mostly gone in for a medical abortion, then there is a possibility that this lady could have antibodies in her circulation. So, which is why even if the husband is negative, we should do a ICT testing. And as we said, even if the lady is rhesus negative, we would still do ICT testing in this pregnancy because, as we said very clearly, non-rhesus antibodies could be present in this lady's circulation, and it could be these non-rhesus antibodies that are causing the positive ICT in the first place. So, which is why, as I said, our protocol is now to test every antenatal woman at booking by an ICT, irrespective of whether she is negative, the husband is negative, the first child is negative, doesn't matter. Any pregnant lady walking into your clinic for booking, do an ICT as a safe practice. Now, next question is there a difference between D antibody and anti-D antibody? Well, there's absolutely no difference between a D antibody and an anti-D antibody. When you just say D antibody, it refers to an anti-D antibody. There is absolutely no difference. You can use both of these interchangeably. Now, latest gift on Teacher's Day, thank you, is if the baby was hydropic when the IUD was planned, how much time would it take for the hydrops to disappear? Now, hydrops generally disappears if you have transfused the full extent. And there is again another debate going on as to whether you transfuse the full volume that you calculate to a hydropic fetus. There are people who would argue that you would split up the transfusion into two if the fetus is hydropic so that you don't run the risk of worsening the cardiac compromise that is already there. Now, having said that, we have done close to 60 transfusions, of which around, I think, 13, 14 of them would have been to hydropic babies. We've always given full volume calculated. We've not had a problem so far. And there is enough data that tells you that you can go ahead with a full volume transfusion. In fact, the center where I did my fellowship in Mediscan, the sir always prefers to give a full volume transfusion. I've never seen him split up transfusion just because the baby is hydropic, and I don't recollect seeing any case of cardiac compromise following a complete blood volume transfusion to a hydropic fetus. So I guess if you are sure that you give blood very slowly and at a measured pace, it is indeed quite safe to transfuse whole volume of blood to a hydropic fetus. But if you're not very comfortable with the idea, there is no harm in splitting up the transfusion. But that means your number of transfusions is going to increase by 2 times. And when your number of transfusions increase, the cost increases, your risk of complications increases. And therefore, if you can give it at one shot, why not give it at one shot if you're sure it's not going to cause too much of harm? What is the dose for an intraperitoneal transfusion? I did not touch upon this for want of time. Now, intraperitoneal transfusion is generally reserved for cases where you have to transfuse before 20 weeks. Now, before 20 weeks, if you plan to give an intravascular transfusion, what happens is the vessel is so small that the bevel of the 20 gauge needle that you're giving the transfusion with is going to be bigger than the lumen of the vessel that you're going to transfuse. Now, if you ask me, can you use a lesser gauge needle? You can, of course, use a 22 gauge needle, but again, if the hematocrit of the donor blood is very, very high, you might find it extremely difficult to transfuse blood through a very thin 22 gauge needle. So 20 gauge is what is generally preferred. And if you look at a 20 gauge needle in a fetus that is less than 20 weeks, the bevel of the umbilical vein or the portal vein where you transfuse is going to be very, very small. So you would invariably end up transfusing intraperitoneally even if you try to attempt an intravascular transfusion. So intraperitoneal transfusion is reserved for such cases. It produces a slower correction of fetal anemia. The anemia would get corrected only over the next week or so, unlike in an intravascular transfusion where the correction is immediate. And therefore, but if you indeed have to do an intraperitoneal transfusion, the dose that you would give is calculated by a rough formula where you subtract gestation age, where you subtract 20 from the gestation age and then multiply by 10. For example, if you have a 28-weeker and you decide to give an intraperitoneal transfusion, you subtract 20 from 28, so that is 8, and then multiply that by 10, so that is 80 ml of blood that you need to transfuse intraperitoneally. Now, sometimes in the odd case, you might find it extremely difficult to get an intravascular access. Now, in such cases, even if the gestation age is beyond 20 weeks, you might be forced to give an intraperitoneal transfusion. Now, if that is the case, as I said, in this 28-weeker, this is how the volume is calculated. You subtract 20 from the gestation age and then multiply by 10. What is the cutoff for exchange transfusion? I think I said this value. The cutoff that you would use for an exchange transfusion in the neonate is 20 milligrams per deciliter of hemoglobin. The moment the hemoglobin, the bilirubin, the moment the bilirubin starts to cross 15, 16, and you find that it is showing an upward trend despite your intense phototherapy, then that is the time when the neonatologist would think of a intravenous immunoglobulin. Now, intravenous immunoglobulin is a stopgap arrangement to try and avoid an exchange transfusion, because the exchange transfusion has got its own inherent risk of including neonatal demise. Therefore, to try and avoid an exchange transfusion, there is a scope for intravenous immunoglobulin. Now, intravenous immunoglobulin is an extremely expensive affair. It costs you around 15 to 16,000 for a 100 milliliter infusion. But if the patient is affording enough and if we can probably avoid an exchange transfusion, there is a scope for intravenous immunoglobulin to the neonate. Now, intravenous immunoglobulin in the mother is also being used in some centers, especially if there's very, very severe fetal hemolysis and fetal anemia before 18 weeks, because the earliest you can do an intrauterine transfusion, even if it's in the intraperitoneal route, is around 18 weeks and not before that. But if you have an extra ordinary case where you have very severe fetal anemia before 18 weeks, say 16 weeks or so, you want to buy time till such time that you can do an intrauterine transfusion. In such instances, it might make sense to give intravenous immunoglobulin, because intravenous immunoglobulin can buy you up to 20 to 25 days time, by which time the baby would be old enough for an intrauterine transfusion. So these are the indications for IV immunoglobulin in the mother and in the neonate. Is spotting in the first trimester of pregnancy an indication for anti-D prophylaxis? Well, I think we discussed anti-D prophylaxis in the last part of this webinar. But if it's a spotting episode that is there and you're sure that the mother is rhesus negative, you don't need to give anti-D prophylaxis unless there is recurrent bleeding and the bleeding is quite severe, and you suspect there is a chance of a fetal maternal hemorrhage in excess of the critical sensitizing volume. Now, but if the spotting leads on to a miscarriage, definitely you would need to give the first trimester dose of 50 microgram. Or if it's a very early spotting and it's a very early miscarriage and you do a DNC procedure, then there is a chance of significant fetal maternal hemorrhage. In such cases, you would want to do give anti-D immunoglobulin. RH, I think I started answering from the middle. There are a lot more questions that went unanswered before this. But okay, it's okay. RH negative 30 weeks pregnancy, ICT negative at 30 weeks. did not receive antenatal NTD. I hope you remember what I said last time about antenatal NTD. There are always more questions than answers. Now, this is again related to antenatal NTD injection. If you have not given ICT at 28 weeks, the mother is rhesus negative, and she comes to you at 30 weeks, you can do an ICT. If the ICT is negative, you can very well do, you can do a repeat ICT at 30 weeks and confirm that she is indeed continuing to be ICT negative. If she is anti-ICT negative, you can give the antepartum dose at 30 weeks. There is no harm whatsoever. Explain about peak systolic velocity again. Now, the reason we look at peak systolic velocity, as I said, is because what you're looking for is increased velocity of blood flow and the hyperdynamic circulation, which is the direct effect of fetal anemia. So, if there is fetal anemia, there is a decrease in blood viscosity because of hemolysis. So, the blood velocity is going to go up, the blood flow velocity is going to go up. Also, because of the decreased viscosity, there is an increased venous return that is driven from the legs. So this again would push up the blood flow velocity because of the hyperdynamic circulation. And to a very small extent, there is a hyperdynamic circulation because the heart is trying to compensate for the fetal anemic hypoxia that is going to be there. So we have a threefold mechanism by which this anemic fetus is going to have a hyperdynamic circulation. And when you have a hyperdynamic circulation, it is the velocity of blood flow that is going to go up, and not the extent of diastolic flow that's going to go up. It is the actual velocity that's going to go up. So therefore, you would want to look at the peak systolic velocity. Now, you can look at the end diastolic velocity as well, but by convention, people have looked at the peak systolic velocity. The normograms that we use to study this is again based on peak systolic velocity, which is why we look at peak systolic velocity in the middle cerebral artery. Middle cerebral artery, because as I said, it gives you a natural 0-degree angle of inclination. In era of paid webinars, but okay. Budding up your thank you. You have had excellent information, no voice. Hats off to your efforts. I came across a case where the titers were high, 1:128. Still, the MCA-PSV mom was not exceeding 1.29. Why? Now, this is a very classical case. You would have to go back and ask your lab what method was this 1 in 28, no, 1 in 128 reported with. Every likelihood that they would have done it by the gel method. Now, if you repeat this gel method 1 in 128 by the conventional tube method, you would realize that it is much below the critical titer for that particular value. As I said, the critical titer for the gel method was 1 in 196, so it's not necessary that a baby with a titer of the mother with a titer of 1 in 128 need not always have severe fetal anemia. The other possibility is that the antibody that was there would have been there in large quantity, but might have been one of those very weak antibodies that would not have caused fetal hemolysis and anemia. How and whom to contact for a recording? Well, this will be available like the first part was available. It would be available on the SFM YouTube channel and on the Life Cells webinar corner. So that will come up in a few days' time. While transfusing blood to fetus, are you holding the needle in place? And if yes, who is holding? Okay, so I think you're asking, do you hold the needle in place throughout the procedure? Well, it's not required because once the needle is in place and it's gone through the myometrium, the myometrium will form a sort of an automatic ligature. It will hold the needle tightly in place, so you don't really have to keep holding on to the needle because it does not generally move from its intended position. But if you manipulate the needle as to take a sample, as to connect the tubings and so on and so forth, there could be, or if there is a significant maternal contraction that comes in sometime during the procedure, the needle position could alter a little bit this way, that way. So if you don't have too much of a leeway, which is one of the reasons why you should always choose a long segment of vein to do the transitions, right? Even if your needle moves a little this way, that way, it would still be within the vascular axis. But if you're going perpendicular to the portal vein, then your margin for error is going to be very little. So in such cases, it might be required that you hold on to the needle so that there is not too much of a slippage of the needle either side. ICT detects IgG or IgM antibodies. Well, it would detect both. I mean, it would detect both IgG and IgM antibodies. But we presume that if it is a alloimmunized pregnancy, then the mother would have had sufficient time to develop IgG antibodies. And it is the IgG antibodies that we're worried about because these are the ones that can actually cross the placental barrier and cause effects in the fetus. And women with EPLA also have positive ICT. That's what we discussed about that case of SLE positivity. Autoantibodies can also cause a positive indirect Coombs test. So it need not always be that it is an alloantibody that you're dealing with. So if you know that the mother is autoimmune, you would want to seek the help of an immunohematologist to tell you whether this is actually a alloantibody or an autoantibody that is causing the positive Coombs test. Is there a role for intrauterine transfusion beyond 35 weeks? Now, beyond 35 weeks, you would want to match the benefits versus risks. Now, what is the risk of delivering at 35 weeks? It's a slight risk of prematurity that you might encounter. You balance that with the procedure-related risk of a transfusion. And I would think that it is better off, you're safer off delivering this fetus if it is crossed 35 weeks, because you're really not worried about lung maturity at that point in time. And you can always correct the anemia by a postnatal transfusion, which is far less complicated than an intrauterine transfusion. It's also far less expensive than an intrauterine transfusion. So I think beyond 35 weeks, it's always better to go ahead with delivery after giving steroids if it is really required. Is it not practical and cost effective doing MCA PSV monitoring in every pregnancy rather than doing ICT for all women at booking? Now, that is exactly what we said. It's about inverting, it's like inverting the pyramid of antenatal care. You always have the shortcut of directly going into monitor the fetus by ultrasound if you know and you're sure that you can do a good job at it. But for a lot of centers that do not have access to routine ultrasound monitoring, and again, if you ask for a routine ultrasound monitoring, this patient has to come back to the hospital every single time, every 2 weekly for a scan. So the cost is going to be higher, the number of visits are going to be higher. Rather, if you do these battery of tests at one booking visit, just one visit, and you realize that this mother is going to be very low risk for fetal hemolysis, then you can avoid all those frequent visits, all the anxiety that it is going to cause, and save, as I said, by a very rough estimate, very conservative estimate, you can save for her around 15 to 20,000 rupees in a private setting. So I don't think there's any harm if you know to interpret these reports to do all these battery of tests at the first visit, because it's just one visit that matters. You could probably save a lot of subsequent visits and a lot of anxiety to the patient, a lot of cost to the patient in her subsequent management. Which site do you prefer for intrauterine transition in your practice and why? Now, we prefer to do the intrahepatic portal vein route because one, that's what I've seen my sir, Professor Suresh, do more often. One, because it's a little less riskier than an intravascular, intracord or an intrafunicular transfusion, even if you choose the placental cord insertion site, because with an intracord transfusion, you have the two umbilical arteries sitting on two sides of the vein. So if your assistant is not careful enough, if you yourself are not very careful enough, you might inadvertently puncture the artery. Now, in most cases, an arterial puncture would seal off by itself within a few minutes. You would not have too much of a loss of blood or a spurt of blood. But remember, a lot of these pregnancies, a lot of these women with fetal alloimmune anemia could also possibly have fetal alloimmune thrombocytopenia. For example, we had a case, she was 11th gravida, had lost all her 10 pregnancies and all her 9 previous pregnancies to rhesus isoimmunization. very obese lady, 135 kilos, if I remember right. We had no chance to give intraportal transfusion because the portal vein itself was at a depth of 17 centimeters from the skin surface. The longest 20 gauge needle that we could get was 15 centimeters. There was no way that we could access the intrahepatic portion of the portal vein, so we had no choice but to give intra funicular into the intra cord axis, very close to the placenta. We went to the cord axis at the cord insertion site into the placenta, but this was at 21 weeks or so, because as I said, in these cases, the anemia happens very, very early. So I think 20 weeks or 21 weeks, the cord was very, very thin and fragile. A small slip of the needle, when the assistant tried to connect the tubings to the 20 gauge needle, it started to ooze from the umbilical artery like anything. I frantically called up Suresh sir. He said it's okay, it will settle within 5 to 6 minutes. But unfortunately, in this lady, it never settled. The fetus actually bled to death on the table. That's the only catastrophe that we had in our 60-odd transfusions so far. It was a very sad thing because it was the 11th pregnancy, and we gave her hope, saying that if you do a transfusion, you can actually save this baby from dying. But unfortunately, this happened. She started spurting from the umbilical artery site. Because we chose to go, we had no choice but to go into the cord insertion site. And that taught us a lesson. It's always, always safer to go into the intrahepatic portal vein rather than the intra-umbilical axis of the cord, especially if it is a higher gravida, because these ladies could also have alloimmune thrombocytopenia. Now, the reason the baby bled to death was because there was severe alloimmune thrombocytopenia as well, which you would expect when a lady has previous 11 losses to or 10 losses to rhesus isoimmunization. So this alloimmune thrombocytopenia was not something that we had anticipated at that point in time. It was very early in my practice back in 2014, and I just started off as a consultant here. So we were not really, to be very honest, we were not really open to this idea of alloimmune thrombocytopenia. If we had known of that entity, we would probably have been better prepared, and the baby would not have succumbed to our procedure. Kindly provide recording. As I said, it would be available on the SFM YouTube channel and on the LifeCell's website. I think we've answered all the questions. So we'll get the first part of the webinar recorded. It is already recorded and available on public domain at the SFM's YouTube channel. You can go to Google and search Society of Fetal Medicine India. Our Society of Fetal Medicine is only one Society of Fetal Medicine, and you can search for the YouTube channel, and it is available. The full recording is available on the SFM YouTube channel. Topics in miscarriages, dose of anti-D. Well, if it's a first trimester event, the dose would be the first trimester dose, which is 50 microgram, which would cover the most cases of fetal maternal hemorrhage in the first trimester. 50 microgram would cover 5 ml of fetal red blood cells and 10 ml of whole blood. So that should be enough in the first trimester. You can not expect to get a fetal maternal hemorrhage in excess of that in the first trimester. Now, I hope you remember last time that I mentioned that the anti-D does not express, the D antigen does not express before 28 weeks, and therefore you really do not need to do a fetal maternal hemorrhage quantification before that gestation. Again, at 20 weeks, the fetal maternal volume, which you're looking at the most, is around 30 ml. So that 30 ml of blood would be covered by the standard dose of 300 micrograms of anti-D. So you do not need to really do a fetal maternal hemorrhage quantification before 20 weeks of gestation. I think all this has been very clearly answered in the first part. So please do log on to the SFM YouTube channel to listen to the first part of this webinar. Please explain with an example the type-specific blood transfusion that you spoke about in case of non-D antibody. Well, if the mother has a non-D antibody, say for example the anti-C antibody, then the donor's blood that you give to the mother should be cross-matched for the C antibody. In the sense, the donor's blood should not have the C antigen, because if the donor blood has C antigen, you would expect that the fetus also has this anti-C antibody from the mother. Therefore, when you transfuse a blood without cross-matching for the C antigen, if this blood does have a C antigen, if the donor blood that you give to the fetus has the C antigen, then the anti-C antibody in the fetus that has come from the mother will destroy the blood that you give by causing hemolysis. So that is negating the effect of your transfusion. So it does not correct the anemia, because the blood that you give, which you expect will not be attacked by the antibodies from the mother, will be attacked because you've not cross-matched for the antibody here. So I hope it is clear. If the mother has a non-D antibody, you would type that specific antibody. You would find out by an antibody identification test what that antibody is, and then cross-match the donor blood for that antibody, so that you don't give a blood that has an antigen that can cross-react with that antibody and cause hemolysis in the fetus, because that will negate the transfusion that you give. I know it's a little complicated, but this is the best way I think I can explain that. Dimension of spleen and liver to measure. Well, there are very specific cutoffs, techniques to measure the liver and the spleen. Now, you can measure it whichever way you want, provided the nomogram that you use is measured in the same way. So the best thing I would suggest is to look at what nomogram of liver length and spleen length that you're going to use. Look at the image in which that they have measured the spleen length or the liver length, and then you would measure the same in your fetus as well. But otherwise, you cannot compare. If that particular nomogram has measured the longitudinal length of the liver, and you take the transverse length, then you cannot compare with that nomogram. So look at the nomogram that you're going to follow, understand how they've measured the length of the liver and the spleen, and then use the same technique to measure liver and spleen length in your cases as well. ICT positive, no facility to identify and quantify the antibody. What about anti-D immunoglobulin? Well, as I said, in routine practice, what we do is we don't give the anti-D when there is a positive ICT. But as we said last time, with anti-D, there's always no harm in giving an anti-D, even if she's ICT positive, if the couple can afford it, because as we said, there could still be a small risk of sensitization from the non-D antibody. Now, having said that, as we said, D is the most prevalent. The chances of other antibodies being there are relatively lesser, unless she's a fourth gravida, fifth gravida, and so on and so forth. So whether or not you would want to give anti-D if she is ICT positive is debatable, but if the couple understand the implications and they are ready to pay for it, there is no harm in giving, I would say. I've been sounded a warning, says that the webinar will end in 4 minutes. So I think we pretty much covered most of the questions. Harish, I think, can we stop with that? What is the cost of an antibody identification test? Not much, it will cost you around 500 to 600 rupees. So the cost should not be a deterrent for you to do the antibody identification testing.
Doctor, we have consumed our time actually. It's been 2.5 hours.
So it was a very long session that we had, because I wanted to convey quite these details, because this is what would actually cover A to Z of daily practice. So I hope that you would have benefited, all of you would have benefited from this particular webinar, and of course from part 1. Again, I remind you that the recording would be available on the SFM YouTube channel and on the Live Sales webinar corner. So do come back if you have to clarify yourself on any of these points. Thank you very much for your patient listening, and thank you for being part of this. Thank you, Harish, I am sorry for having kept you so long. Thank you very much for both these wonderful wonderfully organized and wonderfully aired webinar sessions. Thank you. Good day and good night.
Thank you, doctor.